Okay, so it's 3, 2, 1. We are live now. So, hello everyone. Our today's topic is medical management of BPH. And to present this topic, we have our eminent speaker, Dr. Mohammed Siddiqui. Doctor has done MBBS, MS, MCH, and FMAS. Doctor is a consultant urologist, laparoscopic, robotic, and transplant surgeon. And he's working at Prince Ali Khan Hospital, Safi Hospital, and Wokat Hospital. So without wasting much time, let me hand over the session to you, sir. Over to you, sir. You can start the session. Thank you very much.
Hi, good evening, friends. So we gather here once again for a talk on medical management of BPH. So as we all know, urology is a field where we have a fascination with two things, the prostate and the stones. Since Ayurveda, since history. Even in the time of Sanskrit, we always have talked about stone, we have talked about prostate. And prostate actually being a male exclusive organ, which is also a sexual organ, the fascination has been obviously a bit more with the urologists because most of the urologists are males. And of course, whenever you talk of any disease, we always talk about that. Is a medical treatment available? No one would like to go under the knife. Everyone loves to be taking medicine, even if it has to take for years, 2 years together. So today we start with the medical management of PPH. So here are the two Nobel Prize winners in urology. Charles B. Huggins, the second one, I think everyone knows about him. He's a person who was given a Nobel Prize for the medical management of surgical management of CA prostate by doing bilateral orchidectomy. So this one is very famous. Everyone knows about him. As well as the first person, gentleman, Mr. Werner Fossman. I think many of us will not be knowing about it, but he is one of the, actually a father of angiography, or you can say cardiology, you can say. The field of cardiology, which is the interventional cardiology, has been thankfully here just because of him. He is a person who actually had put a ureteric catheter into his veins and through the femoral and inserted it all the way up to the cardiac heart and got himself an angiography done under local anesthesia. So this is how angiography was born, and followed by that then improvement, angioplasty, stenting, and all those things. So even we owe a lot, or the other way around, the cardiologist or the cardiology field owes a lot to Mr. Werner Fossman and the urology faculty as such. So what do you think when you talk about BPH? Clinically, anatomically, and pathophysiologically. So BPH, what happens? There is a histological change. There is a hyperplasia, as the word says, benign prostatic hyperplasia. What it can cause? It can cause clinical symptoms, which are briefly put into category known as lower urinary tract symptoms or LUTS. And as we have been knowing that LUTS doesn't mean BPH and BPH doesn't mean LUTS. Something like all albumins are not proteins, but all proteins are not albumin. But all albumin are proteins, but not all proteins are albumin. Sorry for that. So this is how we put it in it. So there are symptoms which are lower urinary tract symptoms, which are secondary due to prostatic enlargement. Whether it's a benign or malignant, that's a secondary thing. But these are the symptoms which cause, and hence the patient comes to us. What are the pathophysiologic changes? It is because of the bladder outlet obstruction. This is the old paradigm. We always talked about whether it's a small prostate or large prostate, which one is causing more obstruction, which one is causing more bladder changes. But now, with advent of more scientific things, advent of cameras, which is available, more and more cystoscopies can be recorded, stored, and we can actually see with better CT scan and everything, how actually the prostate is there, whatever the bladder thickening and everything. So here we have the bladder, a normal prostate, enlarged prostate, which of course causes obstruction, residual urine, and because the bladder is working over a period of time extra to overcome this obstruction, there's definitely a thickening of the bladder wall, and which later on can lead to trabeculation, sequelae, and even diverticulums. So we all know how this works. This is a bit of anatomy and physiology, and this is why the alpha blockers are being given. We'll come to that one by one. So what is the prevalence? We all know that the prostate enlargement occurs in all males who are not castrated. So anyone who has a testis there, their prostate is bound to enlarge. Usually it is 50% over the age of 50, 60% over the age of 60, and 70 to 80% over the age of 80. So you can just roughly by the rule of thumb say, okay, after age of 50, every decade the prostate enlargement is seen with a prevalence of 10%. In India, it is 6.7 to 14%. The enlarged gland was reported to cause lower urinary tract symptoms, which is LUTs, which are frequency, urgency, nocturia, hesitancy, intermittency, straining, poor strain, and such. So, by direct bladder outlet obstruction from enlarged tissue and increased smooth muscle tone, as we have talked about the bladder, and resistance within the enlarged gland. So here we are coming to it. There's a prostate hyperplasia, which causes a bladder outlet obstruction. The detrusor responses, for which we have a lower urinary tract symptoms. If it's a non-BPH causes of obstruction, stricture or something like that, the detrusor aging, a neurogenic bladder or something like that. And even you have symptoms when in diabetes or other neurological conditions where you can have polyuria. Pathophysiology of benign prostatic hyperplasia, epithelial stromal cell proliferation, cellular growth factors, altered androgenic environment, genetic disposition, reduce of NOS and nitrous oxide level, increased RH of kinase activity, autonomic activity, inflammation, reduced blood perfusion due to atherosclerosis and ischemia. We'll come to the AU guidelines, as everyone in the world follows the AU guidelines. That is a basic, and it's just like a Bible for us. And we always follow what the current concepts are there with the AU, the American Urological Association, which basic management of LUTS, what are the recommended tests? Relevant medical history, assessment of the LUTS, severity and bothersome score. I believe we all urologists do have this symptom score which they give to the patient, both to know about his symptoms and quality of life. Physical examination includes digital rectal examination, as we know that it is one of the most important things, not only to know whether the gland looks to be benign or it is malignant, are there nodules, how big the gland it is, whether there is a good anal tone or not. So it can help us to know even whether there is a neurological conditions which are dealing with. So DRE plays a very important role, and it is included into the AUA. Urine analysis, serum PSA, as we know, is one of the best indicators for diagnosing a CA prostate, but there are do's and don'ts when it should be done, how vigorous you should do a DRE, and whether you have done a cystoscopy recently or not. But PSA is one of those markers which has revolutionized and changed the paradigm and shift and management of the cancer of prostate. Frequency volume chart, yes, sometimes we are a bit confused whether this is because of diabetes or because of Parkinsonism or because of any other condition. Hence the patient whenever complains that he has got a frequency, urgency, we have to have a frequency volume chart which will help us to diagnose between the two. Recommended test, apart from the questionnaires and volume chart, optional test, flow rate recording. Now, I really like the test whenever I strongly believe this should be done in a patient, a uroflowmetry. It provides a lot of information and sometimes even help us to diagnose between a stricture urethra and a bladder outlet obstruction due to BPH. And even in the case of neurogenic bladder, it does help to a large extent. So if you are doing this test, which is a non-invasive, I'm not talking about the urodynamics, but just plain uroflowmetry, it gives you a lot of information, and then you're more armed with information and you can talk and discuss or suggest a better management with the patient. Residual urine, a bit controversial because so many times it happens, and ultrasonographer has been doing a residual volume and they ultrasound and they show that there's a high residual volume. However, when you examine the patient and you find his bladder is not palpable at all, and then you actually get into the thing how much it should be significant, not significant. Overall, and by a rule of thumb, a 10% of the pre-void, it is significant. If there is more than 10% of the pre-void, it is a significant post-void residue. And if it is accompanied by our upper tract changes, for example, a patient who has got in retention most of the time, or a patient who has got a chronic retention, they usually do come with a large post-void residue, but also sometimes with a bilateral hydronephrosis hydroureter, even though it's a late stage. Then the post-void residue is directly helping you to know what the condition is. Otherwise, post-white residue is not much. It helps you also in few cases where you're trying your medical management, when a person may be needed to give some drug for his overactive bladder, antimuscarinic or a beta agonist like a mirabegon, where you may have to be cautious when you are giving such drugs when the post-white residue is high, because eventually the patient may land up with a retention of urine. So this helps us, not a mandatory, but does helps us. Assessment, as I talked to you about it, the doctor, whether he's a family physician, maybe a general surgeon or a urologist, he examines the posterior of the patient, the anal canal, with a gloved hand, with of course a lubricated lignocaine jelly applied to it. Otherwise, it's very painful. Even the lubricated one is painful, but still you have to. And then we try to examine the prostate, trying to find out about the nature of the prostate, whether it's a firm, soft, and so on, or hard. Is there a symmetry? There's a particular enlargement. Are there any nodules which are palpable, which are indicated of malignancies? And then when you're doing a biopsy, those have to be targeted. And then lastly, of course, then you have to do check the anal tone by doing a bulbocavernous reflex on the patient. As I talked to you, the urofiltry, and I recommend this test. I have doing it almost all my patients whenever they come for symptoms of BPH, even though it's considered to be optional. And if you see that the test is something like this. Patient goes, he's supposed, we have to inform him. Then when he goes for the test, he need not be fasting. He should drink as much water as possible he's comfortable with. Do carry a bottle of water along with himself. Go for the test. Wait there. When his name is called up, he should inform whether he's feeling full or not, whether he likes to void or not. If he feels full, he should straight away proceed for the test. If not, then he should be comfortably sitting there and drinking water till he feels naturally full. Once he reaches the lab, he will be taken to a room where there will be a machine kept in a commode-like toilet, and the gentleman is supposed to stand and void in it. The disc which is there in the commode will rotate with a certain degree, and this gives a graph. Normally a graph is a bell-shaped graph. As you can see here, the x-axis is considered of the timing, the seconds, and y-axis is here, which tells you how much ml per second. When he starts voiding, normally a normal person will start voiding immediately. That's what happens. He starts voiding immediately at his will. The graph will go up smoothly, reaches a peak, plateaus, and then falls down in the same manner as it's reached. So it will be no discrepancy. That's why it's not a bell shape. But at the same time, if you have a patient who has got obstructive flow, so you can see here, it takes a long time to start the micturition. Then the graph doesn't reaches the peak as we have seen in the previous one. It remains stagnant to a certain level. As you can see over here, maybe 10 ml per second. And then it plateaus for a long time. This poor person is trying to strain. And almost he took 50 seconds to empty himself. And he then tries to come out. Or sometimes he may actually use it reducer again with the bladder pressure and restart voiding. So it may have small hills at the end as well. So this is a normal graph versus an obstructive symptom. So what happens, we have just briefly had said initially about the evaluation part. We'll go a bit more in detail. So as we have already seen, the AUA guidelines say we should take history, we should do a digital rectal examination, urine analysis should be done, our PSA value should be done right up front at that moment. These are all the PSA. There is a small controversy what age should be done, which are the more high risk patient. Are we doing too many false negative biopsies? Are we subjecting too many patients for biopsies? That's a controversy which requires a detailed sub-session totally. But yes, in generally, a patient who's going for a health checkup is more than 50 years of age should undergo a PSA annually. If he has got a history of a prostate cancer in the family, the father or brother or someone, then even at the age of 45 may be even required to screen him for the PSA. So Now, his symptomatic scoring, as we have said, we have given the patient the chart. He comes to us. Here is a mild symptoms where the score is 7 or less. If it's a severe symptoms of the patient, then we have to think about treatment modality. If a mild symptom is there, patient may require lifestyle modification, change in food habit, reduction of tea, caffeine, glucose, do not drink too much of water before bed, and so on. This really helps to a very certain extent. It really helps if the patient has concomitant diabetes. If he tries to get his blood sugars controlled, dramatically the symptoms do improve. So you have to go about also his medical illnesses in detail, and these patients do well, but he has to be in watchful waiting, means he should not be left alone. He should be periodically assessed with an ultrasound or a uroflowmetry, or depending on his symptoms, urinalysis and so on. Now, if you are looking at the higher, if the moderate to severe symptoms, you have to alternatively give him some therapy. What does the patient prefers the first time when he comes to you? He will not walk in your consulting room and tell you, doctor, take me to the surgery and operate me. That is obviously going to be very stupid, and neither one of us will be examining and telling him the same thing. After a brief history and all seeing his reports, we always tell him that, okay, so and so is your nature disease. You are not fitting into a very good category. If you want, we can start with you a medical therapy, and this medical therapy has been quite effective, approximately 50% and above. And if you feel good, we will reevaluate you and then keep you on medical therapy. How long and all, that's the second one. If the patient is obviously in retention of urine, or the patient has got a secondary bladder calculus because of stone, he's got upper tract changes because of a chronic retention and so on, those patients may unfortunately land up with straight away surgery, because those are retention. He'll come with a Foley's catheter to you, or he may be required to be catheterized immediately in the emergency and told to see, now we have already obviously 1 liter of plus urine has been evacuated. Now you have gone in retention, and unfortunately the best modality of therapy for you will be a surgery. And surgeries, as all are minimally invasive, all are endoscopic procedure. Choice is up to you whether you're going to do a standard gold standard TRP, or you're planning to do him on a Holmium laser therapy, collab, enucleation, or even KTP lasers, and so on. So this is what the second part. The initially part history is taken. Symptoms are severe. We go ahead with additional diagnosis test. Sometimes if the patient not in retention, as I told you, flow rate is very good, where you can objectively show to the patient, say this should be a normal flow rate and this is what your flow rate is. And unfortunately, your is not that good, or you are likely to go in retention very soon, and you may require to be going ahead with some sort of treatment, mostly surgical. So this is it. And sometimes even on the flow rate, you can find out there's a stricture. As I told you, the flow rates can help you that. Okay. Now, if the patient, what are the indications now? We know that the medical therapy is there. Medical therapy initially when it came, it was an experimental. I do remember the days when we used to give hydrate to the patient, start with 1 milligram, and then keep the patient in the ward for 8 to 10 days, slowly increase it to 2, 4, 6, 8 milligram till he develops hypertension, and then the patient was kept on the optimum doses, waited, observed how his symptoms are improving or not, depending on the, after starting hydrating. And then the better drugs started coming up, and the hypertension part, which was very feared, means the patient would be actually admitted for first dose hypotension, which is now totally taken care of thanks after the advent of tamsulosin. Prior to that, all the molecules which had come, whether doxazocin, terazosin, or hydrate, they all used to cause a severe hypertension, and the patient has to be admitted. And the second thing is to be that if the patient is to fail that medical therapy, then he has to be either failed medical therapy or patient has gone into retention. Those patients were subjected straight away for surgery. But now, even a patient who has failed a catheter trial even once, the current AU guideline says that 2 failed catheterization should be there. It's not like you once failed catheter trial, or 2 failed catheter trials should be there. So presence of refractory retention, any of the following, clearly secondary BPH, recurrent or persistent gross hematuria, bladder stones, renal insufficiency. As I told you, there will be bilateral hydronephrosis hydroureter. In those patients, of course, the renal parameters will be not on the normal range. So he will end up with surgery. So what is the goals of therapy? His symptoms should decrease. bothersome score should decrease, quality of life should improve, prostate size should be arrested, increase in flow rate, that's what the patient wants. Patient has come to you with an obstructive symptom, so his flow rate should improve. And even if when you keep on a medical therapy, we always repeat a uroflowmetry to show the patient how significantly it has improved and he's doing well or not. Prevention of long-term outcomes, complications like retention and so on. Because the first complication which we expect when you're keeping a patient on medical therapy is whether he's going to go into retention or not. Once that acceptable adverse event profile, because we know all medical therapies, as I told you, is to cause severe hypertension, but there are other also side effects of the drugs. So the patient has to be observed, told, talked about it in upfront. These are the known side effects and he should be taking care of it. As we have talked about watchful waiting, the first thing when there is mild symptoms, what we do. So we are saying mild symptoms are one who has got a AUS score which is less than 7. Moderate symptoms is more than 8. Patients are monitored by the physicians, means a urologist. Here we try to say, because he has come to a urologist, mostly the patient come to a urologist. That symptoms are treated with lifestyle modifications. As I already told you, lifestyle modification does plays a very big role in a mild symptomatic patients. Make him walk. If he's obese, ask him to lose weight. If he's alcoholic, ask him drastically cut his alcohol. If a diabetic, ask him to monitor and control his diabetic, because most of the time the polyuria and nocturia secondary to diabetes, and so on. Reduce his caffeine intake, fluid intake before going to sleep, and this will help a lot. Self-management, there's education, reassurance, and periodic monitoring can be reduced, can help and reduce symptoms and disease progression. Disease progression, of course, it cannot, because prostate is under the influence of the hormone testosterone. So as long as the testosterone is there, the prostate, if it's bound to enlarge, it will enlarge, unless until you are trying to stop it some way medically or surgically. So the disease progression basically you cannot, but yes, quality of life and symptoms can be improved. Based on diagnostic evaluation, additional measures or medication may be advised. Yeah, here most of the times we do take help of the physician. Honestly, I'm telling you, because sometimes the patient may be hypertensive, he's taking a thiazide diuretic with that drug, with his hypertensive drug, whether he's already taking, some drugs for his diabetes not under control. So you have to talk to the physician, tell him, somehow can you get rid of the thiazide or something like that. So a few hits and bits here and there can actually drastically improve the patient's symptoms and he'll be better. Medical guidelines, AUA guidelines, now we are going to talk about it. Alpha adrenergic antagonists, that is alpha blockers, to be very simple. And these are the best modality of drug for the prostate. How it acts, where it acts will come down to later. 5-alpha reductase inhibitors, as we have just talked about that, the testosterone causes the prostate enlargement and how to stop this enlargement. So for there, you may have to use a 5-alpha reductase inhibitors, which are given as a combination drugs to the alpha blockers. And these are basically to reduce the prostate size. They do have their own side effects and everything. We'll come to that later on. Antimuscarinics, as I told you about it, the patients sometimes may have more of irritative symptoms, and these patients do well only when you started in antimuscarinic. But remember, they should not have a large post-wide residue, as I told you first thing, because they are, unfortunately, they will land up in retention of urine. And one of the known indications of surgery is retention of urine or refractive retention of urine. So sometimes if you believe that the patient is having large post-wide residue, but he is having frequency urgency, you may not be able to actually give him a treatment for that. But you have to give him only an alpha blocker or maybe 5-alpha reductase inhibitors. Try the combination and see whether he can get off those symptoms. So what are the alpha adrenergic blockers? Recommended for men with bothersome symptoms, whether moderate to severe. Alpha blocker therapy can result in rapid improvement symptoms. Yes, the onset symptoms are very quick, which is not unlike the 5-alpha reductase inhibitors, which take a very long time to act, but this is very quick. Sometimes even there is within a 48 hours, 72 hours, the patient gets the first dose effect and they start feeling very good, better. For a period of 5 to 7 days, they definitely improve a lot. Cause relaxation. Now, where do they act? So they act actually on the smooth muscles in the bladder and prostate. So if we go on the diagram initially, I'll just go back and come to you just to tell you the anatomy a bit, where does it act. So it acts here. This is the bladder neck area. This is the area where it acts. If you enlarge, it acts over here and it tries to pull apart the bladder neck. with this drug, the alpha blockers, and this is how it relieves the obstructive symptoms of the patient. It causes relaxation of the smooth muscles of the bladder and prostate. FDA approved drugs, there are so many, and I just talked to you about it. Doxorubicin and terazosin and Hytrin and those drugs. See, the asterisk is already there. They really required a dose titration because hypertension was severe, and most of the patients were not able to tolerate it. They used to be monitored religiously, kept in the hospital, admitted, and all those things. Thanks, now those days are over, and now we are landed up with the best drug. The first one, which was tamsulosin, it was the best drug. Then later on, alpha-zoshin had come. Why it has come? We'll come down to that. And now the latest molecule available is silidocin. The clinical effectiveness of alpha blockers in patients with bothersome to moderate symptoms of severe looks similar. Common adverse effects, as we talked about, is dizziness and ejaculation dysfunction. So what happened when the patients were started actually on an alpha blocker? The bladder neck is to be more relaxed. So if it is more relaxed, this patient is to be have a better, symptomatic relief. But unfortunately, it also used to cause a retrograde ejaculation. And this was a worrisome males when they were younger side, like 50, 55, where they are very sexually active. And these patients to come back and tell the doctor, I'm feeling better with my urinary symptom, doctor. But unfortunately, I do believe that I'm not able to get that semen, or there's a dry ejaculation at the end, which me or my wife is not satisfied. Because of this, there was a search for a molecule which can work in between, which doesn't open the bladder neck too much, and somehow it can preserve the retrograde ejaculation, for which alpha-zoshin was born. Few of the companies started saying that for sexually active men, it is alpha-zoshin. But alpha-zoshin usually will not give you a very good symptomatic relief. There's a midway where you try to not open the bladder neck too much and try to preserve the retrograde and ejaculation as well. Okay. What about the dizziness? Dizziness is, of course, because of hypertension. There are lots of people who get with all the drugs, whether it's tamsulosin, alpha-zoshin, or silidocin. It is very less nowadays, to be very honest. But still, if you ask me which one causes the most, it is nothing like that. You can try one molecule. If the patient gets hypertension, you can switch over to the other. As simple as that. Nothing more rocket science. If the patient cannot. Why they cause hypertension? As you always know, these are the alpha blockers, and the alpha blockers are also present in the peripheral vessels. Hence, once the alpha blockers are acting not only the bladder neck, they also cause a peripheral vasodilatation, and this is the reason why it can cause hypertension, which can cause dizziness. So this is, unfortunately, we are still searching for a very, very super selective alpha blocker which can only act on the bladder and the prostate, but not on the blood vessels. The day when we get this molecule, definitely the hypertension will be off. But even on that, the main thing is that ejaculation dysfunction. And even in today's generation, we thought once that Indian population actually doesn't talk too much about sex and too much about his erection. But if you go into depth, everyone wants, all men want. So you have to actually go in depth to understand what problem they are facing. Just because a man walks in and he said he has already got 2 kids or 3 kids, you cannot say, okay, bye. So why you're worried about it? You don't need a further family. So what? But yes, it does make a difference, which is sexual lifestyle, and we are supposed to address that. We should take care of it. The second molecule which you talked about is 5-alpha reductase inhibitors. How does it act? It's very simple. Testosterone gets converted to dihydrotestosterone, which is active molecule which causes the enlargement of the prostate gland. And as I told you right in the beginning, the prostate requires testosterone for its growth. So this is how it works. But 5-alpha reductase cuts this. It just blocks this. So it blocks the conversion of testosterone to the active form 5-alpha dihydrotestosterone. So what happens after that is that the testosterone remains as a testosterone. It doesn't get converted to dihydrotestosterone. And hence the prostate enlargement is halted. It is somewhat similar to a medical castration. Not, you can say that it is something like a medical castration, and hence the prostate growth slows down, but it is very slow onset. It takes minimum 3 months to start its action. Hence, it is not given alone. It is always given in combination with an alpha blocker. So the alpha blocker has an immediate action. It will start its action. Slowly, the dutasteride will take over, and then you may withdraw even, alpha blockers. That is how it works, and it is supposed to be. Now, what about it? Which molecules? The molecules which are two most common, which is available, is finasteride and dutasteride. And there are few drugs which are available. If you're looking at tamsulosin, a lot of tamsulosin are available with the combination with even finasteride. But if you're going for dutasteride, it is only available with silodosin, not with tamsulosin. Tamsulosin is still available with both the combination, finasteride and dutasteride, but this one is available only with silodosin, dutasteride. They both have been medically approved, and finasteride even in the low doses is given for people who have hair fall. So it can be if someone who's losing or having a man pattern baldness, finasteride can actually that help over there and to regain his hair growth. So now we come to the third drug, which is just talk about antimuscarinic, and we were talking about that. You have to be very cautious. Take a note: patient's post-partum should not be high, otherwise he will land with retention of urine, and the entire plan of keeping a patient on medical management will fail. He'll unfortunately land with surgery. So recommended for management of LPS without an elevated post-partum residue, and when irritative symptoms are present, as I told you, it is basically given for overactive bladder, like irritative bladder symptoms only. It is not given for obstructive. Obstruction will cause post-partum residue. It is given for irritative. So predominantly it should be irritative symptoms only. Baseline post-partum residue should be assessed. Use in caution, and caution is real caution. 250 is very high. If the patient is having 250, so forget about it. He will be anyway. I would say even if he has 100 cc and plus, do not start him, because 250 means half bladder is as good as he'll land up at retention 101%. Data says use of antimuscarinic may be benefit with some patient. Yes, it does, because if you see, there are a lot of drugs which came in combination, like tamsulosin with tolterodine combination. It was one of the best combinations for patients who came with. Now patients are shifting, pharma companies are more shifting towards the sulfenacin. They have a newfound love for sulfenacin. Maybe they will try to soon come with a combination of mirabegan. So few companies do have a combination of tamsulosin or silodosin with sulfenacin, and I think we will soon be thinking of combining with mirabegan as well. So this is at the moment. Few drugs are available. Tamsulosin is available with tolterodine if you go for, and silodosin is available with sulfenacin if you go for it. But you should be observing. He should not have a high post-partum residue. He should not have a his peak flow volume should be observed. Should not be a very bad one. Otherwise, large will landed with us. And two basic things to remember over here is that all antimuscarinic drugs have bad side effects, because that is the reason why mirabegan has come in picture, because people were not happy with antimuscarinic drug. And if you look for the history of antimuscarinic, there's a long list of drugs. You will start from oxybutynin to tolterodine, derifenacin, sulfenacin, and whatnot. And there are so many drugs which have come. Why? Because everyone found that the adverse effects were too high. The side effects were too high, and then every new molecule was launched thinking of that the side effects could be brought down. And unfortunately, they have almost given up on that, and they have moved toward a newer molecule. The beta agonist is mirabegan, which actually do not have much of the side effects. So this is all the symptoms which are muscarinic symptoms, like dry mouth, constipation, blurred vision. If the patient is given an atropine eye drop, you remember what happens. If for checking his eye number, sometimes if you give him an atropine eye drop, he has a blurred vision. And especially when school children, they go for eye checkup and atropine is put, they have been given officially a letter by the ophthalmologist that tomorrow he will not be able to attend the school because of his blurred vision secondary to the atropine drugs. So that is what happens over here. These are all atropine-like drugs, and they cause the same symptom. They cause constipation, they cause dry mouth and blurred vision. Dry mouth is very severe. This patient, somehow they actually land up with drinking too much of water because of dry mouth. So look at that. If you're giving an antimuscarinic drug and a patient, on the one hand, you ask them to be avoiding fluid or cut down on fluid. because of the LUTS-like symptoms. And on the second hand, he is drinking a lot of water to get rid of his dry mouth. And then even constipation, it can enhance the symptoms or magnify the symptoms of obstruction. So this too will actually negate the entire benefit of an alpha blocker. So that will be used judiciously and better to be used by urologists. I would like to say with let's say a firm voice, it's better to be avoided at that. Anti-muscarinic guidelines. UA recommends anti-muscarinic for men with moderate to severe. Basically, as we said, it should be irritative only. Contradictive men with BPH, yes, some are people very surely they try to avoid it. They will give a merabegan here, and in the women they safely give anti-muscarinic. Medication license like darifenacin, Festool, pterodine, oxybutynin, propivarin, sulfenacin. Actually, there's so many drugs, trospium chloride. So there are huge list of drugs, and whenever you find, just remember this rule of thumb: if you find a huge number of drugs in any particular disease, it means none of the drugs have been the best one. They are just trying to improve the efficacy or cut down on the side effects. Otherwise, you'll stop at one. If you have achieved the best drug, why not? Look at the antacid. There have been huge list of antacids. Antihypertensive drugs, huge list of antihypertensive drugs. Anti-diabetic drugs. Why? Because we are not able to find the perfect drug yet. We are having drugs which give you a better control of diabetes, but at the same time, more of a side effect or something like that. So this is the thing why if the pharma company is going for a next generation drugs, it means the drugs are not reaching to the optimum effect or the optimum side effects which a physician which desires for his patient. That is the reason. Clotridine reduce urgency related voiding and daytime frequency. As I told you, yes, it does, but the side effects, we again have come back to the same thing. So what has been the shift? The combination drug. So there has always been talk when you are trying to actually tackle the prostate. What are you looking at? Are you looking at to just relax the bladder neck and make the patient symptomatically happy, or you're going to stop the disease progression as well? What happens in surgically when you do a surgery, you do a TRP, you actually take care of the disease progression. You remove the prostate gland. So what happens? Not only you have opened the bladder neck, but you have also removed the prostate. So the disease progression itself will go off. It will stop. So same thing medically, we are trying to desire it. How can we do that? So there's a combination where you give an alpha blocker to reduce the symptoms by actually helping at the bladder neck level, but at the same time, if you add the 5-alpha reductase inhibitors, you can decrease the progress or the prostate gland, or you can actually stop the progression of the disease of the prostate gland. So you're actually trying to achieve something surgically, which we have been thinking of doing it over the years. No pharmacokinetic and pharmacodynamic difference of the combination noted compared to single drug. Combination reduces disease progression and worsening of symptoms. Adverse events were more frequent compared to monotherapy. Now here comes the question: in which patients you will give combination drugs? Because just because it's available, it's not the best combination. You should not take it that way. The first thing you should remember is that this has got adverse effect on the libido, because you're actually cutting off the active testosterone. So if there is less testosterone in the body, the male will of course have less desire for sex and his sexual life will be effective. So you should be understanding that before you start with the patient. Second thing, when you reduce the prostate size, the PSA falls. The PSA is directly related to the size of the prostate. The bigger the prostate, the more the PSA. For example, a patient comes with a 40 grams prostate and he has a PSA of 4. But if you have a same patient who comes to you with a 100 gram prostate, that he may be having a PSA of 10. So 10 will be maybe normal for him because there's a huge prostate. You're looking at the bulk, the size. So the more cells are producing the PSA. So this is the reason why the PSA is higher in the larger prostate. But look the other way around. Once you're reducing the size of prostate with the help of medical therapy, the PSA will fall. So what happens here? Here there is a trap. If a patient is started on a dutasteride combination and he comes to you and you are not aware of it, you just talk to the patient and he doesn't tell you the drug and you do his PSA and you'll find his PSA is 4. What do you think mentally? You think mentally his PSA is in the normal scale. But here the PSA has reduced because of the drug. and it reduces by half over the period of 6 months. So suppose the patient is taking since 2 years and PSA is 4, so it's not actually 4, it may be 8. It may be 8. Think in that way, and 8 is not in the normal range. So these patients actually, we may be missing the CA prostate. So you got my point. So this is the few which have kept in the mind, because there are few physicians who think that the combination is the best modality, and they just write every patient coming to them with a silodocin and a combination of dutasteride. But that is not the thing. That's not the case. As a urologist, we understand that, but I like to put it across to our friends, other faculty friends. This is what you have to watch. You just cannot let the patient be there. So if you're starting a combination, please have a PSA before, monitor his PSA so you understand whether the PSA is falling or not, whether the PSA is rising, and whether it's tending towards a malignancy or benign. So this has to be kept in observation. So offer combination treatment, as we talked about that, when the volume is more than 40 grams. Now, how to measure the volume? Who will measure the volume for you? Is a sonologist who measures the volume for you, or on the detailed rectal examination, you can say the volume. There are lots of ifs and buts. Sometimes they are not able to give you the exact size. Some sonologists, some people said my finger is the best guide for me. So I leave it to the audience, because this is again a subtopic of that. But in generally, when there's a large prostate, when that is the reason why you should start a fluoride, not before that. So guidelines like 40 grams. So long-term studies have been then MTOPS, COMBAT, and all they have said key combination is superior than the single, and it reduces the chances of surgery. As I told you, when there is a smaller prostate and the disease progression stopped, so definitely the chance of having going in retention will definitely decrease. So that's no rocket science. This is how the 1 + 1 is equal to 2, or 2 + 2 is equal to 4. So these are the studies which have said adverse events of both drug classes are seen combined. Fine, you should know all those meta-analysis, tamsulosin plus dutasteride. These are the combination studies, the race combination, and all those things. Alpha-1 and muscarinic receptor agonist. Now, as I talked to you about, a few of the drugs do come with that. Tamsulosin comes with tolterodine combination. At the same time, silodocin comes with solifenacin combination, and this also has been combination has been tried to see whether we can take care of the obstructive and irritative symptoms both at the same time. So as you know that LUTS combines of obstructive and irritative symptoms like frequency, urgency, nocturia. These are basically obstructive symptoms, and the irritative symptoms can be other way around. So if you're looking at that thing, so we can target both the things at this with the combination therapy. Yes, combination treatment with alpha-1 blockers and antimuscarinic is more effective, definitely. Combination treatment with alpha-1 is effective in improving LUTS symptoms, yes, because irritative symptoms really get relief. Adverse effect of both drugs combination. Recommendation: use of treatment antimuscarinic moderate to severe relief of storage symptoms, insufficiency. So if there's a relief in storage symptoms and insufficient with monotherapy, you may use combination, but just keep a watch on the post-viral study. So it is not prescribed combination therapy with more than 150. As I told you last time also, the 250 was a wrong statement somehow. It should not be that high. I believe even 100 is high for a patient, but 150 and combination placebo, perfect. Now what the next? As I told you, the antimuscarinic, no one has been happy with it, but unfortunately OAB is such a disease where there's been many drugs, even botulinum toxin injections have been given into the bladder for the same. So the newer range of drug, or newer group of drug which has been launched is the beta-3 agonist. So mechanism of action: beta-3 adrenal receptors are predominantly beta receptors expressed in smooth muscle cells of the retrocyte, and the stimulation is to induce retrocyte relaxation. Mirabegon demonstrated significant efficacy in treated. It is actually, but not as potent as the antimuscarinic. It has got a good relief, good symptomatic what do you call relief. The patient can achieve of OAB with a mirabegon, but not as good as tolterodine or maybe antimuscarinic. That is why there is now a combination of mirabegon with antimuscarinic has started coming in the market. So kind of best of both worlds can be utilized. Recommendation: use beta-3 agonist in men with moderate to severe when this. So this is what in men, you can safely use over antimuscarinic, where the fear of going retention is less in this. So mirabegan has been mainly been evaluated OAB in studies with predominantly female, as I told you, because there is no fear of retention in the female. So that is the reason why it is more commonly used in a female. Now comes the topic which a patient sometimes may discuss with you or may not discuss you, but as a physician, you should know about it. BPH men are men who are actually above 50. And with the age factor, most of the patients do have got this sexual dysfunction. It is not purely related to BPH, but yes, it is a subset. Some patients with BPH will come with sexual dysfunction as well. And even if you talk to any random people pick up in the market, or even you're having a cup of tea with your colleagues or friends, and you talk to them, they will always say, with the age, they have felt that there is some sort of sexual dysfunction. They are not as happy as with the performance as they were earlier. So BPH is no different. BPH is just an additive. It's just like a person who comes and says, I'm hypertensive, I'm 50 plus, but my sexual dysfunction is there, or I've got a diabetes and I'm 50 plus, I've got a sexual dysfunction. Similarly, even a BPH patient comes can be with a sexual dysfunction. But why we are here more focusing about it? Because the drugs also can alter the sexual dysfunction. So you are supposed to know it more as compared to other conditions. So chances of developing BPH or sexual dysfunction increases with age. We all know that. Sympathetic overactivity treatments may cause sexual dysfunction. Here is the point. As I told you about that, the drugs which we are giving for BPH can cause or may cause sexual dysfunction. So you are supposed to know it more. So you, as we said about that, altered ejaculation is there. Some people are talking about erectile dysfunction. This is a very different topic altogether, because if you say, can BPH cause, it has to be very large gland with multiple problems and all those things. So there are multiple issues. Suppose a patient comes with a long-standing diabetes, who's got a BPH and a huge gland. So which one is causing his sexual dysfunction or erectile dysfunction is very difficult to assume. But yes, altered ejaculation is known. Treatment should be tailored according to quality of life. And hence, now what we are talking about it. As you all know, Pfizer came with Viagra, or in a simple medical term, sildenafil. And sildenafil changed the management of BPH, of erectile dysfunction or sexual dysfunction when it concerns to allopathic medicine. Prior to that, there were no medicine as far as promised to actually give you a symptomatic treatment for a sexual dysfunction in allopathy. People used to land up with Hakims and Ayurvedics and try what not. You also know about that. And there was no actually drug available. Sildenafil was the first drug which has been proven and has helped millions of men all over the world for sexual dysfunction. And we all know about it. And but it already had few side effects like the blue eye syndrome, which was very commonly used at those times. And so to take care of the symptoms, which adverse effects, there has been a newer molecule which came after that, which is Teddyphil. There's still a few more molecules, Idonafil and many more, but Teddyphil had come, and this was supposed to take care of the blue eye syndrome, the cardiac part. As you know that sildenafil could not be given in patients who had a severe cardiac dysfunction or MI or something like that, because it could reduce the cardiac circulation, coronary circulation, and those patients could have landed up with a heart attack or MI during intercourse. So there were lots of ifs and buts. So there are newer molecules which are trying to take care of the side effects. So Teddyphil is one of them. And Teddyphil initially also came as a 5 milligram drug for better treatment of BPH itself. It was a molecule. It was launched by a pharma company. There was a lot of study done. Apparently, the studies couldn't actually correlate practically in the patient. So they say there is a difference between in vivo and in vitro study. So in vitro it was showing a very good result, but in vivo somehow it couldn't. But yes, it does helps in erectile dysfunction. We all know that Teddyphil, sildenafil, these drugs do help it. So what should we do? Of course, here look at this. Teddyphil shows good efficacy and safety of improving LE2S. So there was a study, and this was unfortunately couldn't help the patients, but yes, and 5 milligram Teddyphil was supposed to increase the Qmax significantly. That is how it was launched. It was launched almost 10 years back, but no progress has been done on that. So now what has happened? There are few drugs companies have combined tamsulosin with tadalafil to try to take care of both BPH and sexual dysfunction. So what are the take-home messages now? I think we have already completed the entire slides. Aging population, more is the aging population, more the BPH. As I told you about that, okay, in India now the healthcare is better. The elderly are living much better. The lifespan is increasing. So we'll have more of elderly population. So once you have more of elderly population, definitely the BPH patients will increase. As we have already talked about prevalence, like if age of more beyond 50, it's 50%, 60, 60%, 70, 70%, 80, 80%. So look at that thing. Not all male LUTs is BPH, as I talked to you about. It is something very common. LUTs should not be taken as equal to BPH, and BPH should not be equal to LUTs. There are other conditions which also may cause the same thing. Diabetes, neurogenic, and all those things. What about the drug? Which one you should consider? Yes, combination therapy you should consider. And if the patient is not doing well on monotherapy, I would like to say that. A disclaimer, please remember, you should not start straight away with a combination therapy. Start with the monotherapy. If it's not working, then you may not push that. And quality of life, like sexual dysfunction and other things, should be taken care of with this. Thank you, all of you. I hope I have tried to be as informative as possible. If I missed something, you can put me in a question box, ask me. I'll be able to reply to you. Thank you.
Thank you very much, sir. So there are no questions till now, but can you wait for 1 to 2 minutes for the delegates? If any questions comes. Okay.
Sure, I'll see what that's about.
Okay, fine.
It's done, Himanshu. Should we close it?
Yeah, still there are no questions, sir. So yeah,
Okay,
with the
let's close it.
permission. Yeah. Okay. So on the behalf of organizer, I would like to thank you for your insightful and informative talks. Thank you very much for your
Thank you
valuable
very
time.
much. Bye. Good night.
Thank you. Thank you. Bye. Good night. Take care.